Hello, everybody. This is Richard Polin speaking to you from Columbia University in New York, and I am delighted to be participating in this conference, and it gives me the chance to speak about one of my favorite topics, which is non-invasive respiratory support. So, for those of you who have visited my NICU at Columbia, you see lots of babies like this. And this is obviously a baby on nasal prong CPAP. Although we do ventilate babies, most of our babies end up looking a lot like this. And if you ask our nurses, especially our older nurses, about CPAP, they would like to say in a religious context, it's a gift from God. And I'm not ready to say that. I'm driven by evidence. So what I would say is that effective use of CPAP, effectiveness is written in red, can substantially decrease the risk of BPD. I also put that in red because I'm going to show you the meta-analyses which say the CPAP is better than intubation surfactant, but it's hard to show that it is substantially better. The secret in CPAP is not the physician, although cognitively we know it's helpful in managing babies with respiratory distress. It's the NICU nurse. So at the bedside, knows all the tricks of making sure that CPAP is delivered effectively. So here's my outline for the next 45 or 50 minutes. I'm going to speak about the rationale for the use of CPAP as the initial mode of respiratory support. Does how we deliver CPAP make a difference in outcomes? And as you know, there's lots of ways of delivering CPAP through a ventilator or through nasal prongs or other devices. Thirdly, I'm going to talk about how you wean CPAP. Next, I'm going to talk about non-invasive positive pressure ventilation, or NIPPV, sometimes called NIMV, which is an alternative to CPAP, and then provide you with some recommendations and conclusions. So let me start with a case. This is a 750-gram baby whose initials were DT, born following a 27-week gestation. The infant had some immediate signs of respiratory distress. In the NICU, the infant was requiring 30% oxygen via face mask to maintain a saturation of 91%. The PCO2 was okay, 52 millimeters of mercury. The chest X-ray looked like RDS, groundless appearance with air bronchograms. What should be done now? And I want to prove to you this is a real case. So here is baby DT, looking very alert in our nursery. Here are your choices, and obviously I can't see a show of hands while I'm giving this talk this afternoon, but I want you to think about whether you withhold surfactant, place the baby on nasal prong CPAP and observe, or intubate and give surfactant and rapidly extubate to CPAP, and that's called ensure. And sometimes when we administer surfactant using a thin plastic catheter, that's also a variety of ensure. Or lastly, you withhold surfactant and place the baby on some alternatives to CPAP, and that is NIPPV or high flow nasal cannula. And for me, I hope you've all thought of your answer. Answer A seems to make the most sense. I'm going to try to share you the data. First of all, a fundamental concept, and maybe the most important thing I'm going to say throughout this talk, that is if you don't ventilate an infant, it's very hard to cause bronchopulmonary dysplasia or chronic lung disease. And this is one of many meta-analyses, and it's not recent, but most of the studies looking at surfactant use are pretty old studies now. And whether you give natural surfactants, multiple doses, prophylactic surfactant, or early surfactant, these are the relative risks and the confidence intervals. You can see almost everything is statistically significant in terms of mortality. The number needed to treat can be moderately high, but if you look at the confidence intervals of our number to treat, it can be as high as 1,000. But the data, I think, are pretty compelling that surfactant reduces the mortality of babies with respiratory distress syndrome. And I'm going to show you these next two slides, and I'm not going to dwell on this topic, although if we have time for questions and answers the day of the conference, you can ask about this. These are data on LISA, less invasive surfactant administration, used to be called MIST, looking at LISA compared to Ensure in most of these studies. And you can see that they're not very large studies, but LISA is no better than standard Ensure, intubation, surfactant, extubation. And in addition, this is looking at a few LISA studies, looking at the outcome of bronchopulmonary dysplasia. And as you can see here, that LISA is no better than intubation surfactant in reducing the risk of bronchopulmonary dysplasia. But again, these are pretty tiny studies, and it's difficult to draw conclusions unless we see newer studies. But if you're going to critique the early surfactant trials, and some of them are like 25, 30 years old now, a lot of the babies, a lot of the mothers did not receive antenatal steroids, but more importantly, the infants randomized to the control arms of these trials were routinely ventilated without surfactant rather than receiving CPAP. So that's a recipe, if you ventilate without surfactant, for causing lung injury. And these are data, as of now, the most recent data from the NICHD Research Network, looking at use of surfactant across the US, and it appears to be going up. At the same time, the incidence of bronchopulmonary dysplasia, at least through the time of these data collection, about 2012, the risk of BPD was also going up. So it was Leonardo da Vinci that said, simplicity is the ultimate sophistication. And I'm giving you this lecture through an Apple computer, and it was Steve Jobs who used exactly the same phrase when he invented the Apple computer. So I ask you, would you rather use a machine like this, which has so many knobs that it's difficult to know what to adjust, or something very simple like this, where there's very few adjustments other than end expiratory pressure and the inspiratory oxygen concentration? I'm being facetious because sometimes complex babies need the sophistication of a complex ventilator. I'm going to hope you think that less invasive ventilation is preferable. That brings me to my favorite phrase for the NICU, which is the KISS phrase, keep it simple, stupid. So, fundamental question, is the use of CPAP as an initial treatment for preterm babies with RDS evidence-based? When I gave this lecture, I used to say maybe or possibly, and now the bouncing answer is yes, it is evidence-based. And this is one of many meta-analyses comparing CPAP to intubation surfactant from the large or larger randomized clinical trials. It is missing the South American trial, but it's clearly, if you look at overall, if you look at the outcome of death or BPD, CPAP is preferable. I have to say though, and it was part of my introduction, that the benefit of CPAP is pretty modest. Look at the confidence interval, it's up to 0.98. So if we're going to compare CPAP to other modes of respiratory support, whether it be Ensure or NIPPV or high-flow nasal cannula, it has to be used optimally. And the question for us to address is, why has CPAP been only marginally better? And these are the reasons that I've thought about over a long period of time. First of all, there may have been inexperience with CPAP as some of the centers participating in the randomized clinical trial, and greater skills with other forms of respiratory support like ventilators. And I'll say now that CPAP looks deceptively simple, but in fact, it requires a lot of small adjustments by the nurse at the bedside. I also want to make the point that the thresholds for abandoning CPAP are too low. I'm going to show you those in a second, at least the inspiratory oxygen concentrations, which prompted a reading of CPAP failure and then switching to mechanical ventilation. And if you do that too low, you're going to be ventilating many more babies and diluting out the benefits of CPAP. The limited duration of ventilation was a significant issue. If you don't ventilate babies for a long time, there may not be enough time to cause chronic lung disease. I'm going to talk about delivery systems for CPAP, and some may be more effective than others. These are data from Hani Ali. Dr. Ali was a fellow, not when I was at Columbia, but during the 1980s. And when he went to GW, he brought with him the technology of bubble CPAP. And he looked at over a 4-year period, the incidences of how often CPAP was applied, CPAP failure rate, surfactant use, and BPD incidence. He looked pre-CPAP and then during subsequent 3 years, tercile 1, tercile 2, and 3. So you can see in the first tercile, the use of CPAP was marginally more. The CPAP failure rate was way up. Surfactant use the same, and BPD rate even went up. And it was not until tercile 2, and especially during tercile 3, that CPAP failure rate went down to 7.4%. Surfactant use was diminished. and the incidence of BPD was decreased by 2/3. And this is my point about the thresholds for abandoning CPAP are too low. And there are two messages on this table that you're looking at. On the far right is the FiO2, which was considered treatment failure. So you can see it ranged from 40 to 60%. And again, if you use 40%, you're going to be ventilating a lot more babies that you deem to have CPAP failure. At Columbia, just like the COIN trial, Morley, our threshold is 60%. And the other point I'd like to make from this table is that these were not studies comparing intubation surfactant to CPAP. In babies who failed CPAP, they were all intubated and many were given surfactant. So if you look here, percent intubated, percent receiving surfactant. So it's a study comparing not just babies who did well on CPAP, but those who failed and ultimately required intubation surfactant. And the duration of ventilation, both in the CPAP group and the control group, was not very long. In fact, it was less than 2 weeks in all of the studies. And an important message, and this was not dictated by the studies, that all CPAP devices are probably not equally effective. And there are three main kinds of devices commercially available. There's threshold resistor exhalation valves that are found on ventilators. There's bubble CPAP like we use at Columbia. And there's also variable flow nasal CPAP devices like infant flow driver. I'm going to show you two slides looking at the randomized trials comparing one CPAP device or mode of delivery of CPAP with another. And these were devices in which they compared CPAP delivery systems at birth. You see here, the first one was a comparison of bubble CPAP with infant flow driver, and they concluded there was a significant benefit of infant flow driver on oxygen needs and respiratory rate. Interesting, but I'm really only interested in how many babies required mechanical ventilation. And Jan Mazzella, who I know very well, who was the senior author of the study, said it was a very small sample size. He used a single nasal prong, and he doesn't put much emphasis on that study. The study by Tagari, we've compared bubble CPAP with ventilator-derived CPAP, showing a benefit to bubble CPAP and decreasing the need for mechanical ventilation. And these are the studies, the randomized trials, they're observational trials, comparing CPAP systems following extubation. The study by Sun compared infant flow driver versus ventilator-derived CPAP, showing a benefit to infant flow driver in the CPAP failure rate. And the study by Gupta, which I'll show you in more detail in a second, compared infant flow driver to bubble CPAP, showing that bubble CPAP decreased the post-extubation failure rate. And this study is unique, it's larger, and it looked at a very immature population, about 27 weeks. These are data from Gupta from Middlesbrough, England. And on the left, you see the Kaplan-Meier curve. Infant flow driver is in blue, bubble CPAP is in orange. You see the days of CPAP use was significantly less over a period of time. On the right, it looks at babies who were ventilated for less than 14 days, who were then placed on bubble CPAP and infant flow driver. And the CPAP failure rate was significantly less with bubble CPAP than it was with infant flow driver. Those data are mirrored in the animal studies of Jane Pillow and Alan Jobe, published a number of years ago, in which they took preterm lambs with RDS, 133 days gestation. They intubated the animals and randomized them to bubble CPAP at two different oxygen flow rates. I compared it to ventilator or constant pressure CPAP. So the graph on the left, we're looking at the pH. The pH was higher with bubble CPAP than constant pressure CPAP. The PCO2 was lower, so it was more efficient at removing CO2. They looked at oxygen extraction, and oxygen extraction was better with bubble CPAP. It was better with bubble CPAP at the two flow rates of 8 and 12 liters per minute than constant pressure CPAP. And Dr. Pillow concluded that the more efficient utilization of oxygen are suggestive of increased airway patency. And she used the word noise of bubble CPAP. And for any of you who have had babies on bubble CPAP, you know the chest is very noisy. And she thought that the noise of those airway patency explained the short-term improvement in respiratory physiology. But also we're going to make the point that bubble CPAP offers a very small but significant tidal volume. So these are my conclusions about CPAP devices. Limited data suggests that ventilator CPAP is not as efficacious as either bubble or variable flow devices. Variable flow devices offer no proven benefit over bubble CPAP for management of acute RDS. And I'll say, I think the variable flow devices like infant flow driver are gimmicks and are not much clinical significance. And I show you the gupta study, but in that study, bubble CPAP was superior to variable flow devices in reducing post-extubation failure. But even bubble CPAP devices may be different. And this is an in vitro study which compared a homemade device shown over here on the left. And for years, Columbia used this very homemade device, like very similar to apply or our bubble CPAP. And here's Fisher-Paykel. Here's what's called Baby Plus and Airways Development. There may be other devices now on the market. We're looking at the change in volume with these four devices. The blue is homemade, red squares, Airway Development. Fisher-Paykel is black squares, and Bobby or Baby Plus is in yellow. And the change in volume, these small tidal volumes were best in this figure with the Fisher-Paykel, and then the homemade device slightly below it. And we're looking at different, I should have said this, but looking at different biased flow rates so that the lung volume oscillations in vitro study were best with Fisher-Paykel or the homemade device. And this is the actual tracing. It's the pressure waveform. Here's the homemade device, and here's Fisher-Paykel. It looks pretty similar, but I can tell you that the frequency of the upswings in pressure at a lower frequency. But if you look at Airways Development and Baby or Bobby Plus, there's a diffuser on the expiratory limb, which prevents these larger respiratory oscillations. And here's a newer study I thought was pretty interesting. I just want to point it out because I think it offers an opportunity for clinical studies, clinical trials, in which they use an inline high frequency flow interrupter in combination with bubble CPAP using an infant lung, a simulated infant lung model. And they looked at varying frequencies of the high frequency flow interrupter and different CPAP pressures. And they looked at end-tidal CO2 removal at the varying rates and CPAP pressures. Here's what the waveform looks like. Here we're looking at this, we look at the bottom here. Here are the bubble oscillations. And here's when you put on that bubble oscillations plus the oscillator, you can see the frequency and amplitude of those oscillations is much greater. But in fact, tidal volume was actually not greater, but end-tidal CO2 markedly came down from use of bubble CPAP down to where the high frequency flow interrupter was used. And when they looked at varying CPAP pressures, which are shown at the bottom of this picture, 4, 6, and 8, and then varying frequencies of the high frequency flow interrupter, the best frequency for producing the maximum removal of CO2 was at 10 Hertz. I think it's an interesting concept, and that we choose, in fact, we use now commercially available CPAP devices, but that may not be the optimal frequency. And perhaps we should be investigating other frequencies by combining with the high frequency flow interrupter. And now I'm going to talk about something that is a pet peeve of mine, and that's the nasal interface. And there are a lot of nasal interfaces. We use Hudson prong. It's what we used for years and years at Columbia, but there's Apgar prongs, ankle prongs. There are masks sometimes used to provide CPAP, at least initially out of the delivery room. And then there's the RAM cannula. Let me say up front that I respect Dr. Cam. He's a great physician, clinician, and scientist, but I'm not a big fan of the RAM cannula. And for all of those of you who are using it in your nursery, I apologize. The RAM cannula is much different than CPAP. There's no inspiratory and expiratory limb. It's just an inspiratory limb, and with the baby breathes out and around the prongs. And as you know, when you apply the prongs in RAM cannula, they're very soft, and nurses like them. They cause less abrasions in the nostril, but you need space between the RAM cannula and the baby's nares. Generally, you fill about 60 or 70% of the baby's nares. Where CPAP is very different. There's an inspiratory and expiratory limb. You try to get a good seal around the nares so the prongs fit fairly tight, and you like to have a low resistance circuit with minimal dead space. This is what the manufacturer says about the RAM cannula. They say that RAM cannula is registered with the FDA and classified as a Class 1 nasal oxygen cannula. We are unable to share recommendations beyond the scope of our regulatory classification. Uses beyond nasal oxygen administration are at the discretion of the medical practitioner. We recommend up to 4 liters. Anything beyond that is up to each facility. But that's not how the RAM cannula is being used nowadays. So how variable resistance to the RAM cannula? As you know, there are 4 varieties of RAM cannulas: micro, preemie, newborn, and infant. The largest being infant. And here's this in vitro study looking at the resistance of the cannula. And when you get about 6 or 8 liters per minute, you see that the resistances of all the cannulas goes up pretty significantly, but especially the preemie and the micro preemie. How does the resistance of the RAM cannula compare to other devices? This is an in vitro study which looked at all the devices, masks and various commercial devices like Fisher, Paykel, Hudson prongs. And you can see that all size RAM cannulas have a pretty high resistance, and the longer the bar, the higher the resistance. They looked at 3 different flow rates, 6, 8, and 10 liters per minute. But the smallest Hudson prongs, to be fair, and the fullest Fisher Paykel prongs also have a fairly high resistance. So can the RAM cannula be used effectively to deliver CPAP or NIPPV? And my answer I wrote to myself is maybe, but not effectively. And this was a in vivo study on preterm babies about 28 weeks gestation, where they looked at the intraoral pressure delivered by the RAM cannula Hudson prongs and compared it to the set pressure that was being delivered by the CPAP devices, again, using the RAM cannula Hudson prong. And the bottom line is the RAM cannula consistently delivered lower intraoral pressures than the Hudson prongs. Here is the difference between set CPAP pressure and the measured intraoral pressure. Here's the RAM cannula, and here's the Hudson prongs. Hudson prongs, the baby got which was set for the CPAP delivery, and it was significantly lower with the RAM cannula. And finally, this is another in vivo study looking at 14 preterm infants who were put on the servo eye ventilator and received NIPPV using the RAM cannula. And the authors identified 3 different breath types. Breath type where the ventilator was cycling and the baby was taking a breath at the same time. As you know, the servo eye ventilator allows a signal to come from the baby's diaphragm and tries to signal and tries to make sure that the baby's breath and the ventilator are synchronized. The second kind of breath is the baby's breathing, but the ventilator is not synchronizing. And the third is the ventilator by itself and the baby's not breathing. And that breath is shown over here in this square on the slide, on the right part of the slide. So that we know the baby's not taking a breath because the EDI catheter, which measures electrical activity of the diaphragm, shows no movement at all. Here's the pressure that was attempted to be delivered. Here is inspiratory and expiratory flow. But you can see if the baby is not taking a breath, the tidal volume was 0. And this is using the RAM cannula. It's not a comparison study. So again, because of the high resistance of the RAM cannula, it may not deliver effective breaths to a newborn infant on NIPPV. Next question, what's the optimal level of pressure delivered by CPAP? Well, as you know, lung volumes change during the respiratory cycle. Atelectasis is most common during expiration, especially when you have a surfactant deficient lung. And the optimal pressure is going to vary with the disease process, the lung compliance, the device you're using to provide CPAP, and the volume status of the lung. So this is right out of a textbook. Look, it's a pressure volume curve, and the upper one is a normal lung. So as pressure is increased, as lung volume increases to a maximum, and then as pressure is decreased, we have stability because of hysteresis and surfactant, and an FRC is retained in the lung. In the surfactant deficient premature lung, however, it takes much higher pressures to inflate the lung. The maximum is not the same, and hysteresis is attenuated. This is the only study that I know that has actually looked in babies a range of CPAP pressures. These are 20 preterm babies who had CPAP increase from 5 to 10 over 20 minutes. and then decreased back to baseline. They assessed lung volumes using a technique that's called electrical impedance tomography, which measures lung volumes. And these are data out of the research group in Melbourne. And this is what they found. Increasing CPAP reverses atelectasis. But once the atelectatic areas were open, lower CPAP pressure sufficed in the majority of babies. There were no effects on hemodynamics from the higher CPAP pressures up to 10, no effects on CO2, and no significant effect on oxygenation. And they concluded that no single end-descending pressure level will optimize respiratory support throughout the respiratory cycle. But if you have a baby who's not responding, we initially put on CPAP, then maybe to reverse the atelectasis, it's worth going up a little bit higher to try to open up the lung. So this is our data, how we look at CPAP pressures. In the acute phase of RDS, we start with pressures of about 5. How do we pick 5? It's just history. I'm not sure 5 is entirely optimal. Greater benefits may benefit from higher CPAP pressures. There does not appear to be a risk of pneumothorax with higher CPAP pressures, except in the COIN trial. And infants failing CPAP can be advanced up to 8, but there's never been a great study or a large randomized clinical trial saying that 8 is safe for babies. But it's important to remember that infants failing CPAP often fail for mechanical reasons. Things that have to do with how well the nares are suctioned or the CPAP prongs are positioned, and not from insufficient pressure. Weaning is controversial. Most babies in our NICU wean from CPAP in about 32 to 33 weeks. And there have been 3 weaning methods used over a number of studies. You can either gradually reduce the pressure, you can suddenly remove CPAP, take it off what's called cold turkey, with or without oxygen, or you can have sprinting. Take it off for a period of time and then place it back on. What people call stability, or when to initiate the weaning protocol, has varied between studies. And as I look at the studies, there's no significant benefits of any one strategy. Although I'll show you the data in a second, gradual reduction of pressure may be more successful with the first attempt, especially in tinier babies. And here are all the studies I could find in the literature. You can see the number of babies in the study. The largest study was by Jensen. And the Jensen study, he showed that the pressure wean going up from 5 to 4 in babies less than 28 weeks was more successful. Other studies also showed that pressure weaning was more successful. The single study by Todd et al., moderately sized study, showed that sudden weaning was better than sprinting for increasing time off. And it's not clear, I think they used the infant flow driver in that study. I think the data says, especially again for tinier babies, that weaning the pressure a little bit from 5 to 4 makes sense before taking it off completely. And these are the stability criteria used at Columbia: more than 30 weeks, no supplemental oxygen for at least 48 hours, an asymptomatic PDA, no bradycardia desaturation episodes requiring intervention, fewer than 2 self-limiting bradycardia desaturation episodes in the last 12 hours, more than 90% saturation, 21% oxygen, and free of infection. And we have found those to be safe. I haven't done another study looking at other criteria, but these are generally used criteria, both at Columbia and around the country. So an interesting observation was this study from Cindy McAvoy's laboratory. The first author was Ryan Lamb. It was a randomized trial of babies less than 32 weeks gestation who received bubble CPAP for at least 24 hours, meeting predefined CPAP criteria, were randomized to immediate discontinuation of CPAP when they met those criteria, or keeping it on for an additional 2 weeks. And the outcome was FRC. On this graph, the early removal of CPAP is shown, the immediate removal of CPAP is shown in blue, and the extended removal of CPAP after a period of time is shown in red. But here's a 2-week study time point where some babies remain on CPAP and others were discontinued. And you can see here that the babies who were still receiving CPAP had a higher FRC. At the time of discharge, the babies who had received CPAP for an extended period of time also had higher FRC. And it goes along with the hypothesis from experimental animals that CPAP does promote lung growth. So I'm going to conclude about CPAP. The early use of CPAP with subsequent selective surfactant administration in extremely preterm babies results in lower death or BPD when compared to prophylactic or early surfactant. And when I wrote the confidence statement, we said this is a level of evidence 1. If it is likely that respiratory support with a ventilator will be needed, early administration of surfactant followed by rapid extubation is preferable to prolonged ventilation. Also level of evidence 1. All right, let me end now with NIMV or NIPPV. NIPPV uses a ventilator to provide intermittent breaths. And the theory is that if you provide these breaths, you're going to ventilate the baby better than just giving CPAP alone. But the benefits of NIPPV, I'm going to argue to you, are one of higher mean air rate pressure and not necessarily one of better ventilation. So here's the pressures generated by normal breathing. When you put on CPAP, the pressures or mean air pressure is higher. And we use bi-level CPAP or NIMV, the amount of mean air rate pressure is even higher. And that the benefits that have been derived from NIMV are benefits derived from the higher mean air rate pressure. And here's the reason I say that. This is a nifty study by the people in Melbourne again, Peter Davis's group, and it's looking at babies who are receiving synchronized NIMV. Here's the baby's respiratory movements over here. Here's the ventilator that's synchronized with a Graysby capsule and the ventilator they use. And here up top are delivered CPAP pressures. And you can see here, there's an occasional breath that is transmitted to the baby, but many of the breaths, even in a synchronized NIMV, are not being transmitted. And it's thought, and based on data from adult and children, that a lot of these breaths are not getting through because of vocal cord closure. So NIMV, yes, it's possible, do provide better ventilation, but more importantly, they're providing a higher mean air rate pressure. So this is the meta-analysis from the Cochrane collaboration of NIMV or CPAP for preterm babies with RDS. And the meta-analysis over 1,000 babies demonstrated a statistically and clinically significant reduction in respiratory failure and need for intubation. And you see the risk ratios over here and over here, highly significant. No effect on chronic lung disease or mortality. But again, I'm not sure the benefit is not in terms of oxygenation. And this is a recent publication by Bork, I hope I'm saying the correct name, from Journal of Pediatrics last year. It was a secondary study of the largest randomized trial comparing CPAP to NIPPV of Kerpolani. And they included only babies that were never intubated. And they looked at the CPAP failure rate compared to NIPPV. NIPPV in red, CPAP in dotted black line. It was not significant at all. And this is the largest randomized trial. So do we believe the largest randomized trial, or do we believe the meta-analysis of very, very heterogeneous randomized trials? I tend to believe those data. And here's the randomized trial for use of NIPPV or CPAP post-extubation. And you can see that synchronized NIMV is better. In fact, only synchronized NIMV was better than CPAP. Most of the studies are fairly modest, except for, again, the very large Kerpolani study. Here's what the Cochrane Library says. The meta-analysis, 10 trials, over 1,200 babies, clinically and statistically significant reduction in the risk of meeting extubation criteria for reintubation. The number needed to benefit is 8 or 10. No significant reduction in chronic lung disease and mortality. But I would conclude from this study that only if you're going to use a post-extubation, synchronization is important. I think this may be my last slide, but here's my conclusions. Preterm babies with RDS weighing less than 1,500 grams should be allowed time to demonstrate if they can achieve acceptable ventilation and oxygenation. Ventilation for me means a pH greater than 7.2 and a pH less than 65. During that time period, the babies must be monitored closely. If ventilation is not improving with a pH less than 7.2 or a pH greater than 65, or oxygenation is inadequate, we would use 60%. Some people might use 40%. Then I would use intubate the babies. But remember, every baby who gets intubated does not need surfaction. Sometimes babies will get intubated and be in 21% oxygen. Obviously, they had atelectasis, but they do not need additional surfaction. We say if they need more than 25 to 30% oxygen, then we would administer surfaction. What about prophylactic surfactant in the tiniest babies? It's not a question that we can answer right now. I know at Columbia, in this weight range, about a third of our babies will be successful in bubble CPAP. A third will need immediate intubation. A third will fail their bubble CPAP. So whether prophylactic surfactant is important in this population is not clear. And I've been part of studies on aerosolized surfactant. I've seen other studies, and I would tell you, it's not ready for prime time. So I appreciate the opportunity to speak to you today. I hope we have the chance for me to answer questions about this, this lecture, and I wish you good health. Thank you very much.